Yes, we good to go. Okay, great. Good evening, everybody. I'm Dr. Ronak, and it's a pleasure to invite all of you here this evening for No Thrombosis, a national workshop where we discuss interesting cases regarding thrombosis. So it's a warm welcome from Gennova here. And without further ado, I would like to introduce our course director, Dr. Sunil Jain, sir. Definitely doesn't require any introduction from our end. He's the HOD of Emergency Medicine from Jaslok Hospital, Mumbai. That is leading as a consultant head of emergency department there, and he holds a master's degree from CMC Vellore with prestigious fellowships in emergency medicine from AIMS New Delhi and a diploma in diabetes and a fellowship from Diabetes India and AIG as well. There is also the author and reviewer and has significantly contributed to academic resources, including a ready reckoner, and reviewed multiple standard emergency medicine textbooks. There is also certified AHA instructor for BLS, ACLS, and PALS, and an NABH assessor for entry-level HCO and HSCO certification. It's a pleasure to have you here, Sir Mil sir, today.
Thank you.
With this, we also have Dr. Sanjay Deswal sir as our moderator. Sir is the HOD of Emergency Medicine, Max Super Specialty Hospital, Delhi. Sir is an MBBS, MEM, and IIM alumnus, and he brings deep understanding of emergency and trauma care. With years of practical experience, Sir is passionate about advancing emergency medicine, sharing his knowledge, and driving excellence in patient care and system development. His dedication to innovation and continuous learning keeps him at the forefront of emergency medicine in India. His areas of interest are emergency medicine systems, disaster and mass gathering medicine, resuscitation science, academic and technical applications in emergency medicine, EM advocacy, etc. It's a pleasure to have you here, sir, today. We move
Thank you very
forward to our second moderator for today, Dr. Kumar Raj, sir. There is the HOD of Emergency Medicine at ILS Hospital, Kolkata. Sir is a respected leader in clinical care and medical education and serves as a course director for the CCTEM, which is STEMI MEM program, and the president of STEMI's West Bengal chapter. As a NABH assessor, he plays a vital role in elevating hospital standards and emergency preparedness across his region. So it's a pleasure to have you here, sir, today for the No Thrombosis National Workshop.
Thank you. Thank you so much.
With this, we move to our first speaker, Sri Saujanya ma'am. Ma'am is the HOD of Emergency Medicine, Yashoda Hospital, Hyderabad. She's a national president of STEMI and is also leading emergency physician at Yashoda Hospital. She brings a decade of clinical leadership across Apollo Care, Sunshine, and Yashoda hospitals. She's a triple national award winner for innovation in emergency medicine, AI, and healthcare systems. She is the author of India's first book in emergency medicine, AI in EM, healthcare innovation, and infra audit. Her groundbreaking research includes gender specific resuscitation and AI based cardiac death predictions as well. A strategic healthcare leader, international speaker, and medtech visionary driving patient centered care. It's a pleasure to have you, ma'am, today. And we are very eager to know what your interesting case is. And finally, we come to our second speaker, Dr. P.P. Venugopalan, sir. Sir is again the HOD of Emergency Medicine at Maitra Hospital, Calicut. He's a pioneer in emergency medicine and medical education. And of course, I'm sure most of you know him. Sir's journey from a village in Kerala to national recognition reflects his deep compassion and dedication with dual qualifications and in anesthesiology and emergency medicine as well. He has transformed patient care and preparedness across India. As founder of Angels International Trust, he empowers communities through CPR training and emergency awareness, earning a Guinness World Record in 2019 by training over 26,000 people. His legacy continues to inspire future healthcare leaders. And, sir, it's an honor to have you here today. With this, I hand it over to Dr. Sunil Jain, sir, to address the gathering and followed by Saujanya ma'am to take us through her first case. Over to you, sir.
Yeah, good evening, everyone, and thank you, Genova, for giving me this opportunity. So, everyone has we are aware that thrombosis plays a major role in an acute stroke. So, everybody has come across this. So, as last time also, in fact, I discussed with Genova team that the major challenge is only the awareness, which is most and most important. That's we lack, and the stroke patients comes to us very late. Okay, so that's the major concern which we have, but yes, still the awareness in the multi specialty or tier city which is there, which has been easily available. But yes, in the remote places and all, we don't see such a huge amount of awareness. So yeah, looking at this, so I would like to hear two speakers' cases which are there, which are very interesting, and how they have handled this. So I would like to welcome them and just go ahead and present the cases, please.
Saujanya ma'am, over to you.
Can I share the screen?
Yes, ma'am, please.
See. Is my
Yes, ma'am. Screen is visible.
I'm
Could you please put it on full screen mode?
I am trying to do that. Sorry. I paused it. Is it paused?
No, ma'am. It's still not on full screen mode. Could you just go at slideshow?
Yes, I tried doing that, then it got paused. Is it?
Now it's
Yes,
visible.
got it.
Please go ahead.
Okay.
Yes.
Thank you.
Okay. Good evening, everybody, and thank you, Genova, for giving us this opportunity to present to you a case on acute stroke. Yeah. So we have received a patient who is a 42-year-old male with no actual comorbidities. He's not a diabetic nor a hypertensive. And while driving, he noticed that he has a sudden onset of right-sided weakness of both upper and lower limbs 40 minutes before coming to the hospital. He also have deviation of mouth to the left, and there is a slurring of speech as well. So this all event started at 1:30 while he was driving his car. So on examination, he is conscious, oriented, moderately built, airways patent and protected, breathing is respiratory rate of 22 with saturation 98 and circulation within normal limits. And pupils are normal, and we look for pupils to see if there is any abnormality. When these are sudden onset events, bleed is the most probable reason. And his first initial NIHSS was 6 by 42. So coming to the detailed neurological examination, his higher mental functions are normal, speech is slurred. Motor, his power is reduced in both upper and lower limbs on the right side with 3 by 5 and left is normal. Cranial nerves, we noticed him to have a right UMN type of facial palsy with mouth deviation to the left. Reflexes are normal on both the sides. Plantars, right is an extensor and left is equivocal. Sensory and coordination is normal, and cerebellar and spine are normal. So we have a rapid stroke code activation in our hospital. The rest of the systemic examination is normal. With this history and examination, we have activated code stroke in the hospital, and within 15 minutes of arrival to the hospital, we have shifted him for MRI stroke protocol with the initial diagnosis of acute CVA with right hemiparesis and UMN facial palsy to rule out acute ischemic stroke. So this is the MRI imaging which showed an acute infarct in left corona radiata and internal capsule with no involvement of external carotid or internal carotid arteries. So the diagnosis is left MCA territory infarct with right hemiparesis. So this is the picture of the blood vessels and small infarct being seen on MRI. So we have started him with the IV altiplase at a dose of 0.9 mg per kg of 63 mg total. 7 mg is given as IV bolus and 56 mg infusion is given over 1 hour period. And initial dose, the first dose of bolus was given within 25 minutes of arrival to the emergency department. He was continuously monitored for neuro and hemodynamic stability. So thrombolysis was uneventful, speech improved transiently, and it recurred back. The slurring of speech was recurred back. So we did a CT scan before shifting him to ICU to see if there is any bleed or bleeding manifestations. CT brain post thrombolysis was normal, and he was shifted to neuro ICU for further management. This patient has been closely monitored in ICU, and his speech slowly improved over next 24 to 48 hours, and his power was regained, and finally he got discharged from hospital in a normal condition after 5 days of hospitalization with no residual disability. So early stroke recognition and activation of stroke code are the key learnings that we have in this case, and thrombolysis guidelines has been followed, and timely therapy resulted in better outcomes, and post thrombolysis vigilance is very, very important for these cases. So these are the discussion points I would like to raise. Thrombolysis decision with a mild NIHS score. This patient's initial score was 6, and we have taken a decision for thrombolysis in this case. And how can we improve our stroke alert, pre-hospital stroke alerts to improve door to needle time? These are the points that we would like to have a discussion after the presentations. So as we all know, every minute counts in stroke, and the ED is where the brain time becomes lifetime. Rapid triage and imaging saves neurons, and we need to empower ED teams for stroke protocols because most of the decisions need to be taken by the emergency physicians who are on duty. With this, I will hand over to the next speaker, Dr. Venugopalan, and then we can have a discussion.
If there are any comments regarding this case, Jaiswal sir.
So the case was very, very obvious case because the patient had neurodeficit which are, which can be picked up very absolutely by any person working in emergency. But the point was that as Dr. Sajanya has said, ki thrombolysis and low NIHS, right? So this is a case of discussion, and this will really take some time. And I'm sure it's a very interesting discussion we can have after Dr. Venu's presentation for sure.
Thank you, sir.
Yeah, Dr. Sojan, it was a very good case, and it is our one of the bread and butter when we talk about stroke. Definitely, few discussions are there. We'll finish Venugopal sirs and then we'll get back. Okay.
You're on mute.
Let's see. Okay, fine. Yeah. Okay, you can hear my sound. You can
Yes,
see
sir.
my
Perfect.
slide. All perfect.
All perfect. Sir.
Okay.
Please.
Okay. Thank you so much, Gennova. This golden opportunity to present something treating in golden hour or in platinum minutes. And my case, okay. The case is, I'm just using this picture because this is not the picture I taken from the internet. Just not the time in the evening, 16:55. We received, the patient is alerted that is a 71-year-old male with the non-case of CKD, coronary artery disease, diabetes mellitus, developed right upper limb and lower limb weakness with slurred speech. So when case is progressing, when the time is moving on 1713, this my screen is updating with this side one is nothing. You can see all my complete this one. Is it so? Sorry. Hello.
Yes, sir.
Yeah, you can see my entire this thing. Nothing to obstruct it.
Yes, Doctor.
Yes, sir.
We can see everything.
Okay,
We can
perfect,
see that,
perfect.
watch everything.
Yeah, okay, perfect. Yes. So with this, we received a call from the home. There is in our ED command center, and then we have a system, what is called the triple R system, that is established in my previous center, that is a response, rescue, and resuscitation. And this system is a AI enabled virtual with a VR assisted system, and with a 5G augmented one. And because once the connection is established, we can assess the patient on a video-based medical dispatch system through with and also we can also assess them with the video-based call. And in moving forward, the time you can see they immediately just I want to check it. This is the one is obstructing my screen. I want to change. Sorry, 1 second. Okay, because I cannot see because of the screen, I cannot see the. How can we minimize our panel?
Sir, there will be a small minus sign on the top left corner.
Anyway, I'm not spending time on that. Okay.
We can hear, we can see everything very clearly.
Yeah. Okay. So because the time clock sometimes it is not okay. Anyway, case when progressing at 1713, we contacted with the command center. Patient were connected, and then okay, this is exactly I am just presenting with the 8 Ds of stroke chain of survival, and again within 2 minutes. We do the quick assessment our ED doctor assess to the video based assessment, and through the video high resolution video call, and the emergency physician also attended the patient call and convert into a regular audio call with a high resolution video call. This is using an software developed by Apox. There is a apothecary. Through the video call, emergency physician did a quick B-first examination. And this identified this patient is having, it is confirmed that he has a right upper limb and a lower limb weakness. When case is progressing at 1715, we detected, it is identified that it is a stroke symptom. And through automatically our system identified the location of the patient and informed the bystander about this a stroke, and advised them to shift a comprehensive stroke center, and we offered a mobile ICU if they want to transfer. And in 1718, the transportation of patient is started. They just denied that a mobile ICU transfer. They transport the patient in their own vehicle because this is a patient preference. And the entire transport was monitored using this triple R system, and we can see what is happening during the transport and all. And when case is progressing in 715, we also alerted our neuro interventional radiology team And ED cath lab is also alerted. There is a upcoming stroke patient is coming to our ED, and there is a stroke code put it standby. And when the door, a patient is reached at 17:30, patient reached in our ED, and then emergency physician examined the patient, and it shows the patient's airway is patent, breathing is okay, and circulation, BP, blood pressure, is all normal, and disability is confirmed. This upper and lower limb weakness, sliding speech, and deviation of the mouth. And the GRBS is 147, and patient is febrile. When case is progressing, we did the NIH score. The total NIH score was 20 at this time, and the stroke code announced in 1733 that the stroke clinical pathway is activated. The neurology, intervention, radiology teams are involved, and they decided to proceed the patient to ED biplane cath lab. Our ED is one specialty, like we have an ED biplane cath lab inside the ED itself. And then the data in 1317, the patient entered into the cath lab, and from the cath lab itself, take a CT plain BT scene. It is rule out an IC blade in 1738. And 1748, the system is moved to the CT angio. It shows a left M1 occlusion, and left angio, this is confirmed left M1 occlusion. And then decision is to take the patient for thrombectomy, endovascular thrombectomy. And the groin puncture, this is the the angio picture. We saw the occlusion, and in 1755, first the groin puncture done, and the device in 1802, the first angio done, and the first pass of MCA M1 and M2 opened, and then 1715, the second branch is opened, and 1822, we achieved the flow to the TICI flow of 3 level is achieved. And this is the the picture when the flow is achieved. And then yes, this when looking at all the metric, the door to imaging time is 7 minutes, door to groin time is 40 minutes. The onset of the symptom from the home to the groin time is 75 minutes, and door to recanalization time is 55 minutes, and the groin to recanalization time is 27 minutes. And the last is the disposition at 8 o'clock. In the same day, the patient is shifted to neurosurgical ICU. It is monitored for worsening symptom, did an hourly neuro assessment, right upper limb and lower limb power is improved to +3 in each side, and NI score is improved from the 20 to improved to 10, and monitored hourly SpO2, blood pressure, SpO2 definitely continuously, then power charting, GCS, urine output, etc. is done. And the GCS is also improved from E3, M5, E3, V5, M6. And the first postoperative day, morning, 6:20, take a CT brain, and to rule out any bleed. There is no bleed. There is no evidence of bleed, and an antiplatelet is started at 24 hours. And in 10 a.m., patient did a dysphagia assessment done by speech and solo therapist, and clinically is normal swallowing, started oral feed and soft solids, and neurophysiological rehabilitation initiated. And when case is progressing in the monitoring, the basic ECG, ESR, yes, all these things are done. And put it a Holter and also cardiac echo. And echo shows that EF is 60%, no other atherosclerosis and moderate PAH, no other finding. And Holter shows atrial fibrillation, then an anticoagulation is started. And moving, actually only 8D in the stroke chain of survival. I am adding for the two more, that is for the rest of the part. That is a discharge. Patient is conscious and oriented on the second day. Speech is normal, vital stable. Power is regained to 4/5, and rate lower is 3+. And finally, the probable diagnosis. Yes, it is left MCA stroke with left M1, M2 occlusion. And it is undergone a procedure, that is endovascular thrombectomy. The possible cause for this stroke is a cardiac emboli. And the final take home, yes, as we always say, time is brain. A coordinated stroke retrieval system is made this result. We have 15 or 20 cases like that. This one cases that I am presenting, which is immediately we initiated the triple R system. After that, we have a series of cases like this. And what is the strong links of stroke survival chain, that is all the 8Ds will ensure a better D9 and D10. And the integration of the technology in the stroke revival system. What is a triple R? This is a 5G augmented with AI and augmented reality is incorporated. And this help us a visual assessment starting from the home itself and confirmation of stroke from the home itself. And an ED based biplane cath lab that is bypassed several 3-4 days. Again, patient directly get into the cath lab, immediately getting the imaging in minutes and getting the thrombectomy immediately, and that will give a better results. That is all. Thank you so much for the patient listening. Okay, that is all.
Very nice presentation, Venu sir.
Thank you so much.
And sir, blessed and equipped, blessed to have such an equipped emergency department where the cath lab is directly attached, and your intervention radiologist doing thrombectomy straight away for this LVOs. I mean, definitely it is blessed, and and definitely it is good for the patient and even for you as an emergency icon, sir. I mean, thanks a lot for keeping this as an example. I think it's only possible because in your leadership. Even we have a team, but definitely it's not as I mean, starting from the transportation till opening up the large vessel, it has been an amazing job. Amazing job. I think one of the best team all over India you have, and hats off, sir. Seriously, it was very great.
Thank you, Kumar Raj. Thank you so much.
Thank you, sir.
As below the Sir, Venugopal, sir, very good teamwork, I'll suggest, which is there, and a very good setup. And just want to know, like you have taken the patient to cath lab, you have everybody available, so all around the clock and all. Just want to
Yes.
know, sir, what will, like if we would have done imaging and we suppose we didn't get a bleed and we get an acute stroke, okay, which are flat
Yeah.
negative ADC mismatch and all. And
Mm.
if we do a thrombolysis and then we can take to the cath lab or to the DSA lab, would that also
Yes.
be
No.
helpful or not?
I will add on that, Sunil.
Yeah.
This cath lab is the next door to our ED. This is exactly in our acute resuscitation. There's one door of the acute resuscitation bed. That is number one. And even if most of our case, this particular case, we directly get into the thrombectomy. But majority of our cases are, we will start that once immediately the CT is negative, we will start an thrombolysis. Usually we are using tenecteplase. And along with that, parallelly, we will move to the thrombectomy if it is indicated. This particular case is a large vessel occlusion, age, even if this all we consider. Where this particular case, we didn't consider the thrombolysis. Otherwise, most of the cases will, because a dual therapy we will consider. There is a bridging therapy we will be considering.
Yeah, sir. Because the same thing like a Calgary model, which I am talking about, we
Mm.
also follow the Calgary model only. Only
Yeah,
thing is that okay, if in the morning hours or something, if everyone is there, we can take to the DSA. But yes, after like routine daily schedule and in the emergency in the
Mm.
night and all, so that's why I was saying okay, whether this model is being used or not. Thank you, sir.
Okay,
And
for this center, we have three intervention radio. There is a one intervention, two intervention neurologists and one intervention radiologist plus the neurosurgeon. All of them do the thrombectomy. So one person is always just alerting the code, stroke code. We will make sure that one of the person will be available there. That is the reason why it is possible. It's a four people, four senior people. They're good enough and skilled to do the thrombectomy. Otherwise, okay, definitely that choice is an thrombolysis, and then we can get it because now you the total time everything is 27 minutes. The circulation
yeah,
is established.
so yes, sir. So great learning that was for
Yeah,
me
that's
also.
great.
Great learning
And
for me.
one of my resident is did a study with 100 cases comparison. That is all. Probably they will present in Sanjay's conference in the upcoming their thesis.
Yeah, yeah, sir.
Sanjay is our conference.
Yeah. And
Yeah.
and the next thing which you have said, we have been always learning about the 8 Ds, and you have added two. So that was also new for us to have a 10D now.
2D just I added to for the today's function. Only 8 Ds to reach
Yeah,
the
only that's only. So we have been
to
learning about 8 Ds. That's why, and that two is a
the
very good one.
if you want to reach the 9 and 10, you should have a strong link of the
Yeah, sir.
chain. So that is what.
Thank you, sir.
Uh, thank you so much.
Thank you so much. And regarding Sajana ma'am, your case,
Yes.
uh, yeah. So your case was a pretty straightforward and all. It's a very good young male. And all. Just want to know a comment. If that patient had an MR negative, okay, MRI not showing any stroke or not showing any like any clot or anything in the MCO or any territory, and your TOF is absolutely normal, not showing any even stroke in the MRI, so that we consider as an MR negative stroke.
Yes.
Then also, if suppose post MRI you reassess your patient, and if in the reassessment also, suppose your NIHS score was somewhere around 6, right?
Yes.
It is still 6. What would you prefer to do?
Even MR negative, even if it is not seen on flare, there are studies which suggest that mild ischemic strokes, thrombolysis is beneficial. There are in 2019 there was a study by AHA, which the PRISMs and MIRSS, which shows that there is no benefit. But 2025 BM Journal has released a meta-analysis where NIHS score less than 6 and MR negative. There is a benefit of thrombolysis in these cases. There was a study released on meta-analysis with 93,000 patients, if I'm not wrong, which says that low NIHSS mild ischemic strokes do get a benefit with thrombolysis, and we can avoid 90-day disability in these patients. So I just wanted to highlight that part. That's the reason why I have selected that case.
No,
So
very,
yeah,
very, very.
it's
Can I, Sunil?
Yes.
Dr.
Please go
Sajana's
for.
case and Dr. Venus Gopal case, they are two extreme of the spectrum. So like in Dr. Saujany's case, one thing is important that selection of the patient is very, very important. How do you select such kind of patients? Because many patients will not have major weakness, but they might have some kind of disabling symptoms, like partial visual loss or whatever, something which is more important than the NIHS scores. So if the patient, suppose they have some kind of visual defect or some kind of, acute ataxia, like in posterior circulation stroke. So all these cases, other than without considering the NIHS, you look at the benefit, versus risk of thrombolizing a patient. So if you see the benefit risk, then you need to go with some disabling kind of symptoms if it is there, low NIHS mein. As already Dr. Sajana said about 2019 guidelines, that's absolutely correct. And whatever you said is absolutely right, but there will be so many times, what I have noticed in my practice, I would like to share, there will be a lot of discrepancies between neurologist opinion and the ER physician's opinion. And this is a bigger challenge, what I think, like in Dr. Venu's team, there are no challenge. He has bridged all the gaps between ER physicians and neurologists. But in 95% of other institutions, if you go, there are 3 different units of neurologists. 3 will have some other preference. 3, we prefer to have a CT-based thrombolysis. They will have only MRI in their stroke protocol. So, okay, that is okay. With time, it will, so data and the things, everything is important. So on the other hand, if we look at Dr. Venu's case, RRR, the first time when we heard is like 2 years ago, when you came for the first best practices in emergency medicine. I remember that model also, RRR, and you had given that picture broadcast
Yes.
also. RRR was a movie also.
Yes,
So I
yes,
remember
yes,
your
yes.
slides, and
Yeah,
that was
yeah,
very interesting. And
yeah.
this is really something very, very interesting for the future of emergency medicine and stroke care pathways, especially. And for this, again, there's a bridging of, like bridging therapy in your case, which could have been done, but you chose to go for a mechanical thrombectomy. Why? Because there were 2 probabilities that you can go there, because one is consent and finance. Both were absolutely taken care. Patients are rich. You can go ahead and do it. But most of the time in our setups, what happens? It takes a lot of time for the patient to understand why so much of money we should put when we have some advantage with low cost therapy of thrombolysis. So there are so many challenges which happens with time. It will take. But in the case Dr. Venu presented was absolutely brilliant because of the technologies, like last 2Ds, what he said was absolutely taken into consideration, and we are so proud of that system which is working. I think it's working only in your institute, and we are trying our best. Everybody, I'm sure that we want that technology, but everything needs investment, cost, and on top of that, the senior managers and the organizations view and awareness towards that kind of technology. Obviously, this needs to be, these gaps needs to be blocked. So if I take learning from both the cases, both spectrum, low NIHS, extreme NIHS, and then low NIHS, what I feel symptoms are more relevant. If there is some kind of disabling symptoms, we should go ahead. If we want to place some arguments, we can have the 2019 paper, as Dr. Sajana has described now. You can have it pinned in your department to discuss with neurologists. See, boss, these are the written articles and evidences which suggest such kind of patient should be thrombolized. So one point that as a take home, I would suggest all my colleagues that we need to have that paper pinned in our department so that we can have that kind of discussion with our
Wanted to
neurologist.
Sanjay,
Yeah.
2025 meta-analysis report on mild ischemic strokes, which says
Exactly.
thrombolysis is beneficial.
So both the papers we need to be pinned in our department notice board so that we can fight for, because there will always be a discrepancy between our thought process and neurologists. It will be, and between neurologists also. So that we have to bring them together, and to do this, the best way is like stroke review, monthly stroke reviews in your hospital, in your department. You should start. Get people on board. start having that discussion, start presenting your point of view slowly. Discussion is the only way where we can come to a conclusion that yes, not who is right rather than what is right. So that discussion we need to start as ear physicians with the neurologist team, and I'm glad we are doing it very, very nicely, and everybody is trying. Where it is not happening, my suggestion is to start that. And obviously the technology of RRR has to be, when we need your that RRR presentation, what you did, no, in that best practices, so that we can
Yes.
present it to our, in our hospital when we have an academic meet every Wednesday we are having. So one of the Wednesday we can present that also to make people aware about, yes, the technology is there, and slowly things will happen. But both the cases were extremely well presented. There are a lot of learnings, and what my learning was there, I just shared with the entire team. Thank you very much.
Yeah, Sanjay, very good. Thank you very much for briefing everything. Only one thing, why I asked the question about MR negative is like that in my hospital. So me and the neurologist, we both generally deal with many of these cases, and we have done a study also. So we do a thrombolysis for all MR negative. With after reassessment, if they have a still NIHS which is around 5 to 6, we yes go ahead and do a thrombolysis. And as you said, so
Exactly.
we have a code gold, which we call it for the stroke. So like each and every hospital have a code. So we do that, and then yes, after every monthly we do debriefing of all this code. Okay, what went wrong and what could be have. So we basically a kappa which has to be done. And secondly, a live example of a MR negative stroke is me, who has already been thrombolized. So that's why I asked this question there.
Yeah. So there was a controversy when we were dealing with this patient also. He is 42-year-old, and there was, it is not convincing for the neurologist whether to go ahead and thrombolize in the initial examination part. So after the MRI, where we have seen a small internal capsule, in fact, that's when he got convinced and let's do it. But he was skeptical. Initially, patient's speech improved, then it deteriorated. He said, no, no, now this patient is getting into bleed. Now we have to rule out with a CT. That's the reason why I have put that. So all these dilemmas will be there, but still, it will definitely benefit the patient. We still have to follow up this patient over a 90-day period to see how his the discharge time, his power is good, his speech is good, and he walked out of the hospital. But we need to look for a 90-day period to see if there are any bleeding manifestations or anything. After that, I think he should be normal.
So rightly said by you. So it is the patient outcome at the end which will obviously matter the most. So
Yes.
yeah. So thank you everyone for this. Both
Okay,
cases were
I
good.
have
Just one more point which I want to add.
Yeah,
See,
yeah, yeah.
stroke treatment is everything is there, but we as an emergency physician, we should also think about how such things can be prevented. What are the risk factors which leads
Yes.
to stroke? Homocysteine, vitamin B12, nutritional aspect of all these things need to be, think about and assess. And if you have a, like Dr. Salina knows, we are so much into all these nutritional aspects of every disease. We are doing a thesis also, one of my residents, that we have collected almost more than 10,000 data so far. And the nutritional aspect and connection is also very important, that how we can correlate the metabolic syndromes and diseases and the like homocysteine and B12 and fasting insulin and all those which is generally not done in our blood profile or examinations. So that's a point where we can definitely think about.
Yeah. So just few points, Dr. Saujanya. Basically, as per this low NHS score is concerned, anyways, her patient's NHS score was 6. So
6.
even if you take this NHS score that 0 to 4 or 0 to 5, they say as mild, and then 6 you can thrombolize. So it's not an issue. And I had one patient who was basically a singer, and he just had a mild slurring of voice. So and that time NHS would have come to 1 or 2. In that case also we thrombolize, so it's never been a contraindication of not thrombolizing as but NHS is concerned. But my two concern is are why is your hospital practicing a CT based MRI? Why not, I mean, why MRI based thrombolysis? That is one. And second, why are we still to LT plays? Why not 1080 plays? And I've thrombolized with LT plays also, and now I'm doing with 1080 plays also, and I've not found much difference. But 1080 plays has been very convenient because we can do a bolus dose, and the time is definitely saved. Yeah,
Yeah.
Dr. Sajani.
So first question, we have a stroke protocol in the hospital, which is with consensus with radiologist, interventional radiologist, and emergency physicians. And we all have agreed to do a MRI, and which takes us only 10 minutes. The initial ruling out of stroke part takes only 10 minutes, and we get the slot within 5 minutes. So we have a stroke code, or it is announced in a public announcement system, PA system. And once it is announced, whatever case is going on, they stop the case and take our case as a priority. So we have that system in place across all 4 units of Yashoda, and hence we are following MR based, because to decide about interventional aspect also, they are looking at vessels and other things. Wherever it is feasible, I also be favorable for CT based, but to get consensus of neurologists and have a uniform protocol where we follow the stroke pathway, we are doing an MR based one. And your second question is tenecteplase and altiplase are equally used in our EDs. And for this case, we have done altiplase, but most of the other cases we are going ahead with the tenecteplase. So we are
And
seeing equal results with both the thrombolytic agents.
we had one more case with NHS score around 10 to 12, and MRI was normal. We perform MRI only with a wake up stroke or when the time is not confirmed. So we compare the DWN flare, then we think about thrombolysis. And other thing that I was talking, we used to do MR neck also.
Yeah.
So luckily, yeah, that patient had a vertebral artery stroke, and basically the brain was normal. So later we found there was a stroke on vertebral artery, and then we thrombolized also, and definitely the patient has recovered. So even if MRI is normal and we're very much sure about our thrombolysis, then definitely there's no doubt we need to go for a thrombolysis. Even medical legally, it is very important to follow the step.
Actually, Raj, that's the point I was about to make. Because medical legally, you need to keep yourself very very safe. And if it takes 10 minutes for a stroke protocol, then why not?
Yeah.
Yeah, definitely,
Even
definitely.
Yeah.
there is a system established in the hospital to get us MRI slot within 10 minutes. So the minute while we are
Right.
taking the history itself,
My question was also
And
there.
most of the
Dr.
hospital
Sajani.
is like that, so Dr. Sarana, the moment the code stroke is announced, MRI room itself prepares. They also hear that code and they stop whatever is happening. They vacate it for the patient to be wheeled in. Not even 5 minutes, whatever time it takes, they will stop the study
Yeah.
and they will vacate the area.
Then I had a case of microvascular bleeds, and these microvascular bleeds basically we cannot find in a CT scan.
Yes.
So I have done a thrombolysis, which was actually there was a microvascular bleed, and patient later bled. He would have done an MRI for this patient. I think we wouldn't have taken a decision of thrombolizing. So these points are
So
definitely
see, these things are not only necessary. It cannot be picked up on CT. Even if there can be, see, it is always operator dependent. Who is the person reading that CT at that point of time? So if experienced eyes can pick, little less experienced can miss. So, but these are the game plans. जो कि ups and downs will always come in a medical field.
Yes.
So that was unfortunate that somebody who saw could not pick up, but microvascular bleeds can be picked up on CT. That's what I have
not
seen
picked
so
up.
far. Anyway, but that was a miss. So it's better to have a MRI stroke protocol. That
No
is
doubt.
what our units, until unless you have a clear cut, neurological deficit where yes, it is stroke without any scan, you can say you just need to rule out any bleed. And in fact, is there. So MRI is based stroke protocol, which takes 10 minutes at the max. So I think that is okay to have
We can make this
institutional level, because
all
you'll
India
have to
pan India
go
study.
in hand with your neurology team also. This is what I said in my earlier briefing, that this bridge needs to be
Yes.
strengthened. And once these bridges are strengthened and when they will start understanding, yes, we understand stroke, they will probably listen to you also.
Correct.
That's the entire point.
So only message I would like to say is mild NaHS score. Don't hesitate to thrombolize.
Thrombolize. Yeah.
That
Yeah.
will
We
Yeah.
all agree on that.
benefit
We
the
all
Look
agree
at
on
the
that.
disabling symptoms.
Yes.
That is more important. Anything acute onset, loss of vision, ataxia, all such kind of things
Slurring of
should
speech.
not be. Yeah. In these cases, the MRI might be these are the cases where MRI might be negative also initially.
Also,
But
yes.
you repeat after 30 minutes, you will get positive. So it can happen. It can happen.
Yes.
That's it. Anything else? Dr. Venu sir, closing remarks, anything from your side? RRR.
No, nothing. It is very interesting to listen you people. From the different parts of the country, there's a different echoes
Yes.
and different ecosystems. How is reflecting in this platform?
So, any questions from the audience who are there with us? If
So we have one
like any
question.
residents, there are residents also in this presentation. I can see their names also.
And,
So, if the residents have any queries, any kind of enthusiastic experience or doubts they want to ask, this is the right platform to go ahead and ask.
Sir, I think after this insightful discussion, if we can summarize, there's this one question that if you answer, I think everybody will get the right insight here. So, could you describe the ideal code stroke protocol that maximizes efficiency and minimizes the delays, specifically in detailing the roles and responsibilities from an emergency physician at every step? So, if we can just summarize this, I think the audience will truly benefit from the discussion.
Well, I can take that opportunity, and I would like anybody to add, especially Sunil. Sunil has a very nice protocols, and they have code gold also, which I just heard about, and that's worth learning for us also and implementing. So the question is very simple. You need to have a stroke pathway protocol in every unit, which consists of ED physician, neurologist, radiologist, and people who are really involved in stroke care, even a neurosurgeon at times. So different units will have different kind of team, but these are the basic people who should be in the team. Once you make a protocol, you need to have a proper training of these people. All these people should be brought into one table, and everything look alike, think alike, like system should happen. Pre-hospital information is the most crucial thing. Many a times you will see pre-hospital system and EMS system and hospital system are not hand in hand. So your EMS system, I think they are the backbone. Correct me if I am wrong.
Yeah.
Because EMS system needs to be first very, very strong. Your paramedics has to be very, very strong. They need to be well trained about stroke pathways and the clinical signs and symptoms, because they are the first point of contact with the patient. And the more earlier we get right information, the patient comes to the department, quick re-triaging is done at the triage. Then along with the triaging, there are a couple of people who will start speaking to the attendant for the consent, then front office for the financial clearance. So all this goes hand in hand, and cannulation, withdrawal of samples done at the triage itself, and then the patient is moved from the triage directly to the MRI or whatever room you want to move. That is the rapid thrombolysis protocol, with a stroke nurse carrying the thrombolytics in their hand. The moment stroke is identified on the MRI or a CT table, the decision is made. The patient would be thrombolized then and there only, rather than taking there, coming back, then taking into a stroke room. All the decision has to be taken while the scanning is done. So I think this is the only basic thing, and you can write all these pathways and training of these people in different language, in different methodology. But the whole crux is this: EMS system needs to be very strong. That is my point of view. If EMS is not strong, then you will miss a lot of things, and there will be delay in DNT time. So that is very, very important. Then secondly, your triage system should be very, very strong. The most experienced nurse and one of the senior physicians should always be readily available to see any kind of alert which has been raised by your senior nursing triage staff. And then from that area only, everything should be done. You need not waste to, so many times where the EHR is there, okay, पहले registration करेंगे, फिर then financial clearing करेंगे, then उसका counseling करेंगे. So if your EMS system is strong, you can prevent these times also. And one of the case which I have just posted on the chat box, if you can see, is a 6 minutes thrombolysis because we had strong EMS system. Everything was consent, everything was taken on the way only. I've just posted that case. It was published also in
Right.
IAGM. So that is an example of strong EMS system, which I want to say. And before the ambulance has arrived, stroke protocol is all, the code has been announced, the MRI rooms, everything has been green corridor. So all this kind of passion is very important, that you need to be a stroke lover and you need to be more passionate towards these cases. I think these are the simple things which I would like to brief. That's it. Nothing beyond this. I don't think that, of course, gold was really very important, which was a learning for me also. I'll catch Sunil on some other platform to learn about it.
Right, sir. Thank you so much for the wonderful insight. And I
Uh,
Thank
think,
you, sir.
yes, sir, Sunil Jain, sir, please go
So,
ahead.
yeah, Sanjay has covered everything actually. Only one thing
Right.
I would like to add, we generally have a in a team which you have said mentioned, we have all that. We have a counselor also, and as you said, once the patient reaches and you activate like code gold, the counselor and the team always counsel the relative. Okay, if at all it turns out to be an ischemic, so we have to go ahead and do a thrombolysis. So that counseling and consent is already there. One more thing I would like to add is that okay, the patient who we generally do a thrombolysis in an MRI department only. So as everybody says now, Tenectase is only a single dose, a loading. So we give there and there itself. Once the consent and everything is already been taken earlier, and we do. So as you said, the time is very critical here. So the less amount of time we waste, which is most important. So rest all Sanjay has covered. Thank you.
Thank you,
Wonderful.
Sunil. Thank you very much.
Thank you so much, everyone. And I think the discussion itself was so
And
enlightening and
one
insightful.
practical experience,
Yes, sir.
whatever things are happening, the ER physician is everything. He is the neurologist, he is the doctor, he is the counselor, he is the front office guy, he is the GDA to push the trolley also. So we have to be like multitasking as an ER guy for each and everything. We cannot wait that, okay, that is his job, he will do, that is his job, he will do. So that ownership and proactiveness, these two things has to be inborn character of a ED physician who is dealing with such kind of cases. That's it.
Sanjay,
Wonderful thoughts.
one more point. Not that point.
Yes, sir.
My next destiny is I am focusing mainly on rural emergency. Okay, this
Oh, that's
was
great.
like because this whatever I am talking is when I worked in a very tertiary or coronary center. That center we accredited first AHA accredited center, etc. Currently, I am more focusing on rural. How can we salvage more the brain from the rural area? Kerala definitely a complete rural setup is not there, but almost everywhere is a semi-rural or semi-urban, and where these thrombectomy possibilities are not there, and maybe only CT is available. Where how we can do, we are doing such kind of things. Probably I will coming up more result in the next conference or next meeting or next stroke day. More data on that.
Wonderful, sir. Sir, it would be a pleasure to hear your thoughts regarding the same again. So with this, I would like to invite Mr. Deepak Paliwal, sir, from Gennova team, to please give the vote of thanks.
Yeah, very good evening to you all. I'm Deepak Paliwal, Head Neuro Genova. Thank you so much for the wonderful discussion, two case presentations. And I think we have a very wonderful, immersive discussion and perspectives around those cases. A special thanks to all my faculty members, Dr. Venu Gopalan, Dr. Sanjay Jaiswal, Dr. Sunil Jain, and two presenters, Dr. Sri Sojanya and Dr. Kumar Raj. And I think we have a wonderful session. And this was the first edition of the KT Live, which is designed for the emergency medicine, and we intend to continue going forward. Well, Genova is a biopharmaceutical global company, which has created a cutting-edge solutions for manufacturing and commercializing some of the biotherapeutics and life-saving drugs in the space of oncology, nephrology,
neurology, and cardiovascular. Gennova's Tenectes is the pioneering product where first time globally the third generation thrombolytic was approved for the stroke. Tenectes was actually included in the list of drugs for emergency care for stroke management in the guidelines of for the prevention of and management of stroke issued by the Ministry of Health and Family Welfare, Government of India. So I would like to reiterate our commitment for the stroke care. We are actually actively engaged to strengthen the stroke awareness in India and collaborating with the fraternity to build the thrombolysis understanding and partnering with the policymakers for the improved ecosystem in India. Well, so far, Tenectes has saved more than 92,000 lives so far, and a wonderful session, sir, and look forward to connect you all again going forward. And in fact, special thanks to all of you because this is the festive time and taking out your time from your busy schedule has always been a difficult. And on the behalf of Gennova, I would like to extend best wishes of Deepavali to you and your entire family members. Thank you so much for your valuable time. Thank you.
Thank you. Thank you.
Thank you all and wish you all a very happy and prosperous Diwali.
Same to you.
Happy
Same to you.
Diwali.
And see you all at MCon in Delhi
Yeah,
very soon.
of course.
Yeah.
Just 10 days and total disorientation is there. All right. Thank you so much. Thank you so much for having us.
Chalo, meet
Yes,
you
sir.
there. Yeah. Thank you. Bye.
Thank you.
Bye.
Thank you, everyone. Bye bye.
Thank you, sir. Thank you, everyone.